So anyways, I'm Bev Lear, really happy to be able to introduce Dr. Amin Azzam, and we have worked together for a very long time, but I want to go through giving credit where credit is due. He's had so many honors, so many presentations, but let's begin at the beginning. Undergrad at University of Rochester, medical school, Medical College of Virginia, of course, residency here at UCSF, and a 2-year fellowship here in psychiatric genetics. Not to be stopped, he also went to get a master's degree in education in UC Berkeley. And I think the thing that I was most impressed with, of all the things, because it was the most unusual, is that he's the faculty lead the UCSF course on improving Wikipedia. So go Amin. He has led groups since 2008. They started with time-limited CBT groups for chronic medical conditions. I cannot tell you how appreciated and welcome those groups were. Myself, everyone I know, we were like, that's wonderful. How do we get into these groups? And also, he worked in our coast clinic, which in the beginning, and for the first year or 2 years of the pandemic, we required 6 staff, and he ran a brief coping skills-based group for the staff and faculty at UCSF with regard to the pandemic. He has now been running supportive, psychoanalytic-oriented groups for chronic medical condition patients along with chronic psychiatric problems. And again, it could not be more needed, appreciated, and welcome for what he does. So I will now turn it over to Dr. Azzam.
Woo-hoo. Thank you.
Thank you.
Andy's going to do some audio visual changes here. And so I'll just want to remind the, here we go. This is off. Okay, this should be on now. All right, so for the Zoomers who are joining late, I always start my talks with a dad joke. So I'm going to give you the opening line of the dad joke again and see if you can get it before I give you the punchline. Maybe I'll give you the punchline at the end of the thing. So feel free to guess the punchline during the talk, and Bev will be monitoring the chat to see if anybody is quick enough to get it. The opening line, once again, my wife gave me an ultimatum, her or my addiction to sweets. My wife gave me an ultimatum, her or my addiction to sweets. And guess those punchlines throughout the chat, and we'll reveal towards the end. Okay, let's dive in. Boom. All right, so I'd like to start with the land acknowledgement. And Bev, don't forget, I'm going to make you go around the audience and have the in-person people read. And so I'll read this first one, but this is going to be an interactive talk. So you got to walk up those stairs and make those large number of people in the audience actually use their voices. The privilege of being roomers instead of Zoomers. Okay, we would like to acknowledge the Rheumatoid Arthritis people who are the traditional custodians of this land. We pay our respects to the Rheumatoid Arthritis elders, past, present, and future, who call this place the land that UCSF sits upon their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Rheumatoid Arthritis community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Here on this slide are some links to some additional resources to learn more. I'm a huge educator, so I'm a big fan of learning more about land acknowledgements. And next, I actually want to acknowledge my patients. I have learned so much from them. It's been a real privilege to serve them and to learn alongside them through their journeys of chronic medical conditions and life and lived experiences. So I really want to improve that. There's a chat request to fix the audio. Rahina, I'm on the podium. Can you just let me know if it's there's an echo. Do you mind unmuting, Rahina? I don't know if you're allowed to, and just tell us what the problem is. We'll try to fix it. Old friend. And by old, I mean that in both ways. You still can't hear. Rob, how about you? Is there an echo for you too? You're fine. Okay, and Cynthia? You're good? Okay. Rahina, it's just your echo for some reason. I'll do my best to just stay anchored at the podium. I apologize for the echo for you. Okay, so once again, just honoring, acknowledging my patients. And I'm a big fan of disclosure slides at the beginning. I normally have to do my academic disclosure slide, and I'll do that next. but I've also been lately taking to doing personal disclosure slides as well. I think it humanizes the communication and the connection between the speaker and the audience. So this is me, my early years and my middle years. And I wanted to say, I gave a talk to some child psychiatrists who afterwards came up to me and said, hey, that's not really early years up there. I mean, what about all the developmental trajectories? So full credit to our child psychiatry colleagues to acknowledge that's my early professional years and my middle professional years. And here is my academic disclosures. So top row, I've been in academia my whole career. I'm never leaving academia. I love it so much. And I've also been involved in some non-academic pursuits that require disclosures. Fortunately, none of those disclosures have anything to do related to the presentation I'm giving to you today, but I do want to disclose them because I feel a lot of innovation is happening in our partnerships outside of our academic ivory towers, and it behooves us as academics to lean into those collaborative efforts and relationships. Okay. First time for you to walk, Bev. Here comes the first quote. I'm going to tell a story and invite one of the audience members to read a quote from one of my patients. So, start with a love story. I don't know any of the people in the audience residents. Show of hands. No. Okay. Well, residency is hard, and in my first year of residency here at UCSF, as you heard, it was pretty intense. There's a lot of administrative paperwork, and there's a lot of long hours. There's a lot of good teaching, and I want to honor my faculty members who taught me in that year. And in my second year, I had the great privilege of working with Rob Derrick at the VA in a group for HIV-positive veterans that was a 6-month longitudinal experience. And I fell in love with group therapy. It was pretty darn amazing. I had never heard of group therapy before. I didn't know anything at all about it. And I was like, wow, what is this? It's amazing. Going fast forward in my third and fourth years, I had the privilege of doing some groups under Bev's supervision. And then I did a longitudinal 2-year group for patients, mid-functioning patients with bipolar illness, and just loved that. Co-led with a resident each year. And then I just stayed in group therapy ever since. And so I hope you can hear and will hear that my passion for group work, and hopefully you'll all come to appreciate the power of groups ahead by the end of this talk. Towards the end, here's the formal learning objectives. I want you to understand a little bit of core theory and logistics around group psychotherapy, appreciate some of the reflections from my patients, and then we're going to look at the literature on the quantity and quality of evidence around group therapy for chronic medical conditions. Here's the first quote. Pick a random audience member and please read it aloud.
Pretty random. Yes.
Is it on? Oh, yeah. I was referred to a group for people with chronic conditions. I was very reluctant to join any group therapy. Over time, I have realized how very supportive, helpful, and caring this has become. I look forward to the group every week. I even schedule appointments so that I don't have to miss it.
So you're going to see these quotes from different patients of different ages from different ones of my groups. I currently run 5 longitudinal long-term groups, and so this is a patient from the Thursday morning group. Okay, so here's the structure for today. We're gonna talk some theory. We're gonna have those quotes peppered throughout, and we're gonna talk about the evidence from the literature such that it is, and then I'll close with some limitations, caveats, and Q&A. All right, let's talk fundamentals first. When you think about group therapy, I love to point out that we are mammals, and by definition, mammals like being around other mammals. So we need to be around other mammals, and there's nothing like a global pandemic that can sort of point that into stark cognizance. So hooray, hooray for the ability for you all to be in the audience with me this afternoon. I appreciate you for coming. Secondly, group therapy is one of the rare opportunities for therapists to see our patients' behavior with other people as a way to see how they behave as a window into their outside world interactions with other mammals or other humans, really. And it gives us an opportunity as therapists to speculate about ways that their behavior may be contributing to dysfunction or may actually be areas of strength that we can encourage them to lean into to further develop because it's serving them well. And you don't really get that in one-on-one therapy. Certainly with couples therapy, you're going to see the ways the couple interact, but that is a unique relationship generally compared with other mammalian relationships. So, so one of the big powers of group and the theory behind it is real-time observation. Many of you are familiar with Tuckman's stages of group development: forming, norming, storming, performing, and then later added the adjourning as a sort of suffix to that. That's true in all groups. Even today, we started forming with the dad joke. Actually, we started forming when the presenting team and I were debating what the final head count would be before we started. We all took some playful bets around that, and I will reveal the winner of that also in the Q&A. But I think these stages of group development apply in psychotherapy groups as much as they do in all other groups that we interact with in society. I love pointing out to my trainees when I'm teaching about group therapy that there's always a balance between my, your, and our needs. It's a nice, succinct shorthand, but it really applies. So there's a balance between my needs as an individual patient, your needs as another patient in the group, and our needs as a group as a whole to ensure psychological safety and equity and usual appropriate distribution of time, effort in the group across members' needs. So it's a just constant reminder, there's always a balance between my, your, and our needs, and let's make sure we're attentive to that. One of the things that's really powerful about a group therapist's skill and work is that we have to tend to all of these parallel forces all at once. So in teaching about group therapy, you'll draw vectors, arrows of influence from one member of a group to another, or double-headed arrows, and those vectors are flying everywhere in groups. So it is far, far, far from boring. It's got to keep your group therapists on their toes at all times as they're tending to that. And now that we do hybrid groups, tending to the Zoomers and the Roomers concurrently. Really great stuff. I love group therapy. All right. Let me talk a little bit more about sort of different types of groups. You have, I've drawn a visual representation for you to try to make it easier, just to think through the different elements of types of groups. And so the first thing we should think about is the duration of the group. So Babs already alluded to the fact that I ran some short-term CBT groups in my past. So we can think about those as fixed length groups. And if we draw that visually here, you can see a start and an end date that are however many weeks that is, right? So that's an example of a fixed length group, but you can also, of course, have open-ended groups, which means you keep coming to group as long as you find it therapeutically beneficial and your insurance pays for it, or you choose to continue to pay out of pocket. A different element to consider is whether it's cohort-based. And in a cohort model, everybody starts together and everybody graduates together. So here's an example of 4 patients all starting and ending a group together. And here's another second group. So when I ran short-term CBT groups, they were cohort-based, so everybody started and ended together. In contrast, you can have closed-ended rolling admissions groups. So here's a visual representation of that, right? So you've got 4 members in this group, but it starts with 1, then 3 people, then 4 people, and that first blue person graduated, so you're down to 3 people, but you can have this rolling admission, so you can have other people starting and ending whenever they finish their groups. Bev alluded to the COPES program that I was a part of, and I ran COPES, short-term CBT COPES groups for UCSF employees, and they were 4 weeks, and anybody could start in any given week, and when they finished 4 weeks, they were done. So if they missed a week, they could come back a month later and get that booster shot and still have the 4 sessions. So rolling admissions, short-ended or fixed-length groups. Okay, and then the last thing to think about is the structure. And right here, I'm talking about what the therapist does. So you can have much more structured groups like cognitive behavioral therapy, very structured, very therapist manual, key content you're covering each week with homework you provide, and patients respond with a homework each week. And you can have the opposite end of the spectrum, which I'm going to call supportive group therapy, which may be you follow the patient's leads each week and what the focus or foci of that week is based on their clinical needs or requests. So that I want you to think of as a continuum rather than a either or black and white, but those are the 2 extremist examples of structure groups. Okay, so just in terms of my own clinical work, from 2008 to 2013, I ran cohort-based closed-ended CBT groups for chronic illness, for patients with chronic illness. And we ran 3 cycles of those groups per academic year. They were 6 weeks groups. 8-week groups. There was a 6-week manualized therapist treatment that I followed, and I bookended it with an open introductory group and a closing graduation group because it felt like the patients needed that. In contrast, the work I've been doing for the last several years is rolling admissions, open-ended supportive groups for patients with chronic medical conditions, which looks like this. So here's one group of 3 members just for visual brevity, and here's one with 4. My groups are really 10 members each, maximum cap of 10 members per group, and I have currently 5 groups, and I'm eager to start a couple more when the department is ready. Okay, quote number 2. Bev, pick another lucky audience member, please.
Patients with chronic conditions have no choice but to become educated on our own conditions, as well as the finer points of navigating the medical system. That means we can share insider information that doctors aren't privy to, as well as what we've learned about enduring physical dysfunction and how we can access services.
Thanks for reading that. Appreciate it. And these are quotes verbatim from my patients. And I'm sorry, that patient is currently 46. All right, let's talk about evidence from the literature. So I'm going to show you a number of slides, and I'm just going to frame them for you here. In each of the slides, we're going to talk about what the therapeutic modality is for this study, what population they were studying, what the outcome variables were, and then my top line summary for you to summarize the literature. Okay, so we're going to start with an article about cognitive behavioral therapy in groups for patients with major depression who are end-stage renal disease or have hemodialysis. This is a published study from Brazil, and the group modality they used was a 12-session weekly group CBT versus no groups at all. The population that they were working with are patients with chronic hemodialysis with major depressive disorder. There were 41 patients in the groups, and they used 44 controls to compare and contrast. The outcome variables they used, they had the Beck Depression Inventory, something called the Mini International Neuropsychiatric Interview, which is just a diagnostic interview to confirm the presence of major depressive disorder or not, or other psychiatric conditions. And then they used a form called the Kidney Disease Quality of Life Short Form. So, okay, big picture summary. What happens when you give hemodialysis patients groups? Well, the mean participation in groups was 78.5%. The mean homework compliance was 87.8%. And the study group had improvements in all outcome variables, as listed there. And in service of top line summary, I'm not giving you the raw, specific details, but we can dive in if you want. And what I thought was really interesting about this study is they looked at those patients 9 months out after completing the short-term CBT group. So, and all those improvements were still present. So if you will, not like well, I guess I'll in comparison to our COVID, where we need some booster shots, our COVID vaccines, it seems to be, at least in this study, that CBT, short-term CBT groups for patients with hemodialysis doesn't need a booster shot 9 months out, which I think is kind of cool. Okay, study number 2. In this case, we're looking at supportive expressive group therapy for women with metastatic breast cancer. And this study comes from Australia, and they were looking at survival and psychosocial outcome from a randomized controlled trial. Supportive expressive group therapy was compared with relaxation therapy. And so the pair of those two was compared with relaxation therapy alone. And the supportive expressive group therapy was weekly for 90 minutes. The relaxation therapy is what it sounds like. Teach individual humans how to use self-relaxation techniques in service of dealing with metastatic breast cancer. Obviously, the population were women with metastatic breast cancer. In this study from different sites in Australia, there were 147 women with breast cancer who had the combined SEGT and relaxation therapy and 80 controls. They did a 2-for-1 study this way just to ensure effect size. So the outcome variables they used here, survival, new onset depressive disorders, a scale that was measuring helplessness, new onset trauma symptoms, and then social functioning. Again, there's more details in the actual article itself, but here's a summary. Group psychotherapy does not cure cancer. I regret to inform you that we haven't figured that connection yet. So the women died equally across these two groups, and there was a reduction in the new onset of depressive disorders in patients who were exposed to the supportive expressive group therapy, and there was reduction in the hopelessness, helplessness, and there was improvement in social functioning. Kind of cool. Time for another quote, Bev.
Thank you. Testing. Oh, okay. Something that is truly remarkable to witness is the ability for human beings from various backgrounds and ages coming together around a variety of medical scenarios to share their powerful experiences and stories, resulting in a walk together that brings healing to each individual. This is the power of sharing and connecting and listening, which in turn becomes healing. As much as people are strapped for time or not in the place to walk with each other at 100% capacity, they still come. This speaks to the power of Dr. Azzam's therapy, leadership, and his group.
Thanks for reading that. That's a 45-year-old patient of mine from the Tuesday morning group. This individual has multiple sclerosis. Here's another study. Okay, this is a study looking at telemental health in group therapy, and this was a secondary analysis of a non-inferiority trial. All right, in this study, the therapeutic modality is video or remote therapy, group therapy, versus in-person group therapy for anger management. And I'd like to point out this study was published way before the pandemic, so it's kind of cool to think about like the push for telehealth, telemental health long before it became obligated because of the pandemic. In this case, the population were male veterans with PTSD. This study, I think, comes out of the US, I don't remember for sure, or the UK, one of those two. The population was 112 veterans. And in this case, the study was actually just looking, there was other things they were studying, but they wanted to look and see, by the way, is video-based therapy at least as good or non-inferior to in-person groups? So the outcome variables here were things like therapeutic alliance, patient satisfaction, treatment credibility, attendance in the groups, homework completion, and attrition from the groups. And our top-line summary, slightly stronger therapeutic alliance in person compared with telehealth visits, but there was strong therapeutic alliance in both modalities. As I recall, it was like 4.5 versus 4.6 on a 5-point Likert scale. So everybody seems like they're connecting with the group therapist, whether they're in person or telehealth. And there was no significant difference in any of the other outcome modalities. So one of the things I really liked about this study was just the notion that, hey, group therapy works even if you're remote. I'll just, as an aside, point out when we pivoted to all remote group therapy at the beginning of the pandemic, there's a couple of things that emerged that I didn't expect. One is what I like to call free pet therapy. So my patients' pets will jump into their Zoom laps, and the other patients are like, oh, isn't that cute? And it's fabulous because it's free. And because you also get to see patients in their home environments. And so there are some therapeutic strengthening of the alliance and bonding because I get to see them in their home environments. All right, from here on out, I'm going to show you a bunch of studies that are from this book. So Ranjan Roy, this book was published in 2008, Psychosocial Interventions for Chronic Pain. And Ranjan Roy is a professor in the Faculty of Social Work and Department of Clinical Health Psychology in Manitoba. And I'm going to give you a couple of quotes from the book before we dive into the specific literature. Okay, first he points out, it has to be acknowledged the dominance of CBT in treating chronic pain patients. And that evidence is quite impressive, including numerous randomized control trials. I mean, it's effectively indisputable by now. Even when it was published in 2008, there's plenty more studies that have confirmed what we already proved, which is CBT hella works, okay, in groups. But one critical question he points out for us is that all psychotherapists must ask, what's the fit between that therapeutic modality or the particular problem the patient has and the choice of therapy? I like to think about this as informed consent. What are the pros and cons of group versus the pros and cons of couples versus the pros and cons of individual? And at least you can make an informed consent decision about the types of therapeutic modalities you elect to engage in. Because if your main problem is with your coupledom, group therapy may not be the perfect fit. maybe you should be doing couples therapy. Lastly, Ranjan Roy points out, it's possible that the dominance of CBT to treat chronic pain has had a dampening effect on research to explore the effectiveness of other forms of therapy. And our research in that book suggests that indeed that may be the case. We have one type of therapy that is just dominant. We're missing the opportunity to investigate other forms of therapy in terms of their therapeutic efficacy or effectiveness. All right, so let's look at some of the literature that Ranjan Roy has summarized for us. There are 10 chapters in this book. Each one is dedicated to different types of interventions for chronic pain. So you can see the description here: cognitive behavioral therapy, interpersonal therapy, family, couples, psychodynamic therapy, and working with individuals with abuse and chronic pain, brief therapy, and of course, my focus here today, group therapy. And I'm just going to summarize the summaries without going into the original articles. Nevertheless, I think it's still illustrative for us. Oh, another quote. Bev, you're getting your exercise today. Or you can read it if you want.
Yes, I'm going to read it. Community, empathic, active, engaged listeners who understand your story. Most people, medical professionals included, don't truly understand the patient experience, especially when suffering with lifelong chronic conditions. Some healthy, non-chronically ill people can't truly empathize or sympathize from a healthy, constructive way unless they too are suffering from something similar. However, in the group, they just get you, understand, AKA I see you, avatar reference, like a band of brothers, so to speak. A circle of supportive yet firm accountability, a space for venting frustrations, and a sounding board, brainstorming, think tank for developing solutions, strategies to cope.
Thanks, Bev. This patient was in a parking garage and slipped on some sort of patch of water in the garage, fell, fractured a hip, which turned out to be undiagnosed multiple myeloma. Has led to chronic pain and sort of hip problems. And so at the relatively young age of 36. I see some questions in the chat. We'll come back to those at the end. Thanks, Rob and Rahina, for your questions. All right. In this book, we're looking here next at a study on comparative efficacy of individual and group psychotherapy. So here now, the therapeutic modality was a meta-analysis of 23 different studies that were looking at individual versus group therapy. And the population was, of course, variable depending upon the study, but all of the patients had chronic illnesses or diseases of some kind. And the outcome variables, of course, are going to be variable across the studies, but all of them were assessing treatment efficacy in some way, shape, or form, which allowed the meta-analysis to proceed. Top line summary here. Only 23 studies across 50 years of research were included in this meta-analysis. And so the authors made an extremely important point here. Across these studies, only 12% of the analyses had sufficient sample size to determine the differential effectiveness of group versus individual. So you're not going to find anything that works if your study size is too small, your population is too narrow. So you need to expand the study size to look for an effect size that we're going to deem clinically significant. And as a result, only 92% of the variables produced, a whopping 92% of the variables produced non-significant t-test results with that low power. So again, the problem here is just the studies are all just too damn small, with too few numbers of patients to really assess a comparative efficacy of individual versus group therapy. Here's another study in the book. This one we're looking at social support interventions. Do they work? So here I want to define what social support interventions are. There were 4 different types. The first one is social support for family or friends of the patient with the chronic illness. The second one is peer support groups. Third one is support groups for providing social support. So the main focus here is being together with other people who have that same disease. And then the last one is social support skills training. So some specific techniques, let's say relaxation techniques or breathing exercises that would be useful when taught in a group. So these are 4 different forms of what we're going to call social. We're going to lump together as social support interventions. And there were 100 studies that looked at this in this publication. Those 100 studies had a diverse patient population, as you see here: patients with overweight, alcohol dependence, drug addiction, breast cancer, multiple sclerosis, bulimia, rheumatoid arthritis, and what the authors called, quote unquote, psychiatric problems, which we can presume means a DSM diagnosis of some kind. Okay, so lots of studies, amazing, 100 different studies on social support. Here are the outcome variables. These studies compared the intervention or that form of social support versus no treatment, or they compared that form of social support versus standard care controls, or they compared that form of intervention versus some alternate intervention. Social support versus CBT, social support versus individual therapy, et cetera, et cetera. Okay. 100 studies, lots of power here. 39 of those studies said the intervention was better than the other thing in that other column there, whatever that other thing was. 12 studies said social support therapy was equal or equivalent to that other thing. 22 studies said the intervention was partially beneficial. And I put that in quotes, obviously, because it depends on the outcome variable they were measuring. 17 studies said doesn't work, which means that 83% of the studies showed some benefit of some kind of social support groups for chronic illness. However, the authors point out none of these were randomized controlled trials, so absolutely acknowledging the hierarchy of evidence across our different types of clinical interventions, or studies, I should say. One more. Manny, your microphone works. Let's have you join the crew.
So my eyesight is good today. Dr. Azzam's sessions have provided invaluable in several ways. They provide a safe environment to share fully about your disease. They build a community and help build self-respect. The group allows for a perspective of trust fellow travelers and becomes a true support structure. I regularly share about the value of the group and believe society could benefit greatly from more of them.
Thank you, sir. This individual I've worked with since the pandemic, before the pandemic. I miss seeing him in person, but he has a rare condition called rat lung worm disease, that's the sort of lay term for it, that he contracted on his second honeymoon in Hawaii, and also has multiple myeloma and has had multiple other health conditions. And he calls himself the luckiest unlucky man on the planet, just given that he's been able to receive some CAR T-cell treatment here at UCSF and had like amazing curative results. So one of those like awesome success stories, but also a series of chronic conditions through his life. And he is currently 69. All right, here's another study. Now we're going to look at rheumatoid arthritis specifically. So these are 2 studies that were summarized in this article. First one was looking at mutual support groups and stress management versus no treatment at all. And the second study was looking at cognitive behavioral group therapy and social support versus social support only versus no treatment, a 3-arm study. Population in these 2 studies, obviously patients with rheumatoid arthritis. Yeah, and the outcome variables, I don't know. I didn't read the original literature articles. I'm only summarizing the summary, but here's what Ranjan Roy summarizes for us from these articles, from these authors' work. First study, there is no significant difference between mutual support group and stress management versus no treatment for patients with rheumatoid arthritis. And so the authors made the argument, hey, maybe this is too weak of a treatment modality or insufficient for this severe chronic medical condition. Study number 2 showed that there were reduction in anxiety symptoms in both treatment arms, so CBT and social support or social support alone. Both of those did better with reduction in anxiety symptoms compared to no treatment, but all 3 arms showed increased depression and increased disease activity, that being rheumatoid arthritis. So I'll say again, group therapy doesn't cure rheumatoid arthritis, just like it doesn't cure cancer. Here's another study. Now we're going to look at fibromyalgia. In this case, this study involved weekly 2-hour classes that were education, exercise, and physical training, relaxation techniques, demonstrations of those, and group problem solving. So that was the format of what they called pain school. population here were 71 patients with fibromyalgia. In this study, elegant study design, they actually matched patients by age, sex, and visual pain score who were patients who did not have fibromyalgia. So now our control group is non-fibromyalgia patients, but with a similar demographics, if you will, in terms of pain. And the outcome variables they looked at were a global functioning score, which included all these subscores here: social withdrawal, general life satisfaction, family problems, easier contact with others, and relaxation level. So these are the subscales of that global functioning score. And our results. There was significantly better global functioning in the study group. All the subscales were better, but none of them were statistically significant. And there was an average reduction in healthcare utilization of 10%. So the patients with fibromyalgia used healthcare systems 10% less than their matched controls over the study period. And some patients with fibromyalgia actually returned to work in the study groups. And that was compared with more what I'm calling workplace dropout in the control group. So those individuals with chronic pain who didn't have fibromyalgia, many of those dropped out of the workforce, presumably because of their health condition, though that's a presumption, compared with the fibromyalgia patients, who actually some of whom went back to work. Pretty cool. All right, let's go to another study. Oh, sorry, not another study. I'm going to read you a couple of other great quotes from the book. So McRoberts and colleagues conducted a meta-analysis of 23 outcome studies that directly compared the effectiveness of group and individual interventions when they're used within the same study. This study results indicated no difference in the outcome between the two forms of interventions, but their findings bolster the cost-effective argument in favor of group therapy. I'll point out that I see a hella more patients than I would see if I were doing individual therapy, just because of the convenience and efficiency of 10 patients per 75-minute visits. One reason for the very limited use of group therapy methods other than CBT in treating chronic pain conditions can in part be explained by the very popularity of CBT. One major omission noted in the body of research reviewed here was the lack of information on patient characteristics that may predict positive outcome. Much work remains to be done in that respect. And I totally agree, because I am also not studying which of my patients drop out or which patient health conditions may be more amenable to the kind of group intervention that I'm providing. I'll read this one. It is through Dr. Azzam's wise and fearless leadership that I have been able to open up in such a sacred space, wherein I have found the most inspiring peers, and with them, the strength to confront and cope with the indefiniteness of my pain. I could not imagine doing this work with anyone else at the helm. Thank you, Dr. A. This is one of my patients with chronic pain, 34. This patient has chronic active headaches after a brain aneurysm rupture, and has been able to survive that because the rupture happened in front of an emergency room, thank God, but has now these chronic residual headaches several years later, and this patient is 34. All right, that's the evidence from the literature such that it is. I want to move us ahead to limitations and caveats, and then we'll do some Q&A. All right. Many of you are familiar with measurement error, and different quotes on measurement. I'm going to just read these all aloud to you. So left to right here, Francis Bacon says, whenever you can count, you should can. Einstein, some of you are familiar with this quote. I love this quote. Not everything that counts can be counted, and not everything that can be counted counts. Gives us an important reminder to think about what it is we choose to measure. In contrast, Robert Heinlein says, if it can't be expressed in figures, it is not science, it is opinion. Lord Kelvin says, if you cannot measure it, you cannot control it. And Doug Pratt says, if it moves, it can be measured. And if it can be measured, it can be changed. So I'm going to stand alongside these individuals who have quotes on measurement. And I'm going to say that my scientist brain absolutely agrees with the need for structured evidence. So let's think about what that structured evidence should be. If I were to do this research, I would be very curious to look at the dose and effect size of group psychotherapy for patients with chronic medical conditions. I'd want to know how frequently should the groups meet and how big should the groups be. I would also be very curious to know whether cohort models or rolling admission models are more effective or less effective than the other approach. And because I've already alluded to this concept of booster shots with COVID, and one of these studies did a booster shot, can you have like graduates from the groups come back for some sort of once a month recurring event with any of the graduates from any of the previous groups, just to get that booster shot of camaraderie, collegialship, and reminder of some of the skills that you learned or tools that might be useful or effective in living with that disease that still hasn't been cured, even though you're no longer in groups. And I would love to look at cost effectiveness stuff. I feel like we grossly underutilize groups in most mental health departments because patients seem to think they want individual therapy first. And gosh, if you're in a group, that means that you're getting a less effective form of treatment and you're not getting all eyes on all attention on your eyeball, on your problem at once and the whole time. I totally am convinced that this is more cost effective. But, oh, sorry, and one more thing, and then I'll do the but. It would be really cool to look at this prevention of what I'm going to quote in quotes as superfluous visits to other healthcare providers around visits that weren't really medically necessary or weren't really beneficial to the patient and could have been avoided if, for example, patient were in a group, weekly therapy group. So the big but here is that I am not interested in doing this research. My academic pursuits are in medical education and health professions education, and I do my scholarship in other domains. And I'm proud to say it because I will offer for you that just like primary care providers want evidence to support their treatment decisions, they don't necessarily want to conduct the endocrinology studies that say how often you should draw a TSH or whether you should treat T4 with a certain dose of medication or whatnot. So I am out and proud about loving science and loving research, but not needing to be the one who does that research on this therapeutic modality. But if any of you trainees are interested in collecting this evidence, I have a fabulous patient population that is more than willing to fill out surveys and measure the efficacy of the groups beyond the subjective quotes that we see in the session. All right, final quote. Bev, it's yours.
Okay, if you're here to help me, you are wasting your time. But if you've come because your liberation is bound up with mine, then let us work together. Lilia Watson.
This, like one of my, like several of my other patients, is a fellow healthcare provider who, in this case, has a chronic condition that is preventing this individual from working as a healthcare provider in their chosen area of health service delivery. So this individual chose to send me this quote with instead of personal sort of reflections, which I thought was really cool. And this individual is 39. I am ready for your questions. And by the way, did I mention how awesome group therapy is now, which I love it? And what we've just done is, you know, here, building community, mammalian connections by forcing you in-person audience people to join, by hearing more voices than just mine. And before we go to the Q&A, I gotta give you the dad joke answer first or at the end. What's your preference? Do we give the dad joke punchline before or go to now? Okay, so for those of you that join late, I always start my teaching with a dad joke. I make the students, even the Zoomers, guess it in the punchline in the chat, just as a way, again, to build community. And so the dad joke I gave you today was, my wife gave me an ultimatum, her or my addiction to sweets. And the dad joke punchline is, the decision was a piece of cake. The decision was a piece of cake. I think it's pretty good. All right, so let's look at the Q&A. Do you want to queue them up for me, or how would you like to do it? Rob, you're talking about the breast cancer, metastatic breast cancer study, I believe?
Yeah, thanks. I mean, I want to just thank you for the amazing review of the literature, and for I didn't come expecting like stand-up comedy, so I've been laughing intermittently throughout. It's been a really wonderful talk. Yeah, you know, I started a cancer support group when I was a resident years ago, and was encouraged at the time. There was the David Spiegel study on metastatic breast cancer. He followed women, I think it was for years, and a Fauci study with malignant melanoma, where in both cases there was actually health benefit, rather dramatic. And I guess I just wanted to throw that in there. wondering if that question is really resolved about health outcomes. And at least in the study that you referred to, how long were those women followed to be able to say that there was no effect on survival?
Yeah, I'd have to go back to the original literature to see. I'm thinking it's less than a year, to be honest, in terms of survival impact. So, so obviously one could continue those studies out further longitudinally to see if in fact that there might be some impact for those who survived the metastatic breast cancer longer. The Ranjan Roy book actually talks about the opportunity to conduct many more of these studies, and they make a specific point, which I think is spot on. Now that we're in an era of electronic health records, accessing all of those outcome variables becomes tremendously easier than it used to be in an earlier era before we had all this access. And so in the large health systems that we're a part of, big data, this is exactly the kind of studies that should be done to sort of more accurately answer those kinds of questions. Thanks, Rob.
I'll add a question. A lot of the research has been done on particular diagnoses, and that makes a lot of sense given that you're doing research. But I think one of the things that I know about your groups, having a few patients in them, is that we have lots of patients with highly unusual, rare disorders, rare diseases, unusual tragic accidents, and it would seem that they're helped by seeing other people like them, even though it's not their diagnosis.
Yeah, you lobbed me a softball. Thanks, Beth. So appreciate that. When I was designing my groups, I had a sort of a design inclusion-exclusion criteria decision to make, and that was exactly the point you're raising. Should we limit all of these groups based on the specific disease condition or the specific symptoms? We could even just limit it to chronic pain, for example, but chronic pain comes from several different disease sources or in different parts of the body. I made a choice not to limit them. In hindsight, I think that's really been a wise choice because sometimes it's really hard to find people with these rare diseases, but more importantly, the shared experience of living with chronic symptoms, regardless of the disease, biologic disease source itself, it surmounts the need for similarity in the disease course. So similarly, you saw the decades of age range in my patients when we need to do some shuffling with our department, clinical services, and so I needed to shuffle my patients. And I debated whether I should keep them in decade bands, like people with chronic disease in their 30s may be having very different lived experiences than people with chronic disease in their 70s. I made a decision to let patients choose which groups they want. So by definition, the decades sort of intermingled, just because different people have different priorities and time availabilities. Again, I think that's proven wise because the life spectrum challenges are more meaningfully processed and explored because there are people in other decades of life than if they were only all people in their 20s or 30s or 50s. Thanks. Please, tell us your name too. Oh, wait, you gotta wait through your microphone. So we'll wait. Here comes Manny. Thank you, Manny, for bringing that up to our room participant.
Thanks, Manny. Hi, thanks for this talk. My name is Ethan. I have a couple questions. I'm curious, even though there are these rare conditions people with rare conditions that you see, are there particular conditions that occupy most of your groups? And also for these folks, like how do they come to be in your group? And do they have the option to do individual therapy sometimes? And then if so, how do they sort of end up between that option and the group option?
Sure, yeah, thanks so much. And I assume the Zoomers heard the question. If not, just someone just flag me down and tell me. But the referrals to my groups are currently word of mouth. I am totally open to exploring sort of a more expanded sort of formal processes, expanding our group services. I'm a big teacher. I'd be thrilled to bring group services back into our residency program or our clinical psychology programs. It doesn't have to be me. There's great teachers of group therapy. Some of them are on the Zoom here as well. I want to acknowledge some of those other passionate group therapists who I'm sure would be interested in exploring teaching the next generation of group therapists how to do this work. with my individual patients, with my group patients, I don't do individual work with them, but occasionally I'll meet with them one-on-one if they need a sort of specific support from me. Many of them have their own individual therapists that they see concurrently for the groups. And so sometimes we'll talk about their individual work in groups. They'll bring that work to the group work. And then your first question was around the predominance of symptoms. Chronic pain is clearly the most predominant one that I have for a lot of my patients.
I know you already presented some data on Zoom versus in person. What's your experience been? And you're also running hybrid groups.
Yeah, thanks again for that softball. So when we came to this building, the rooms are designed to allow hybrid group participation. So patients can choose on any given week whether they come in person or whether they prefer to be on Zoom. So in the rooms, just like these cameras here, will automatically zoom in on Zoom, automatically sort of zoom in on the active speaker, which allows the field of view of the remote participants to be able to be changed according to what's happening in the room. So with my patients, we made the choice to make this optional, or hybrid every week. So patients can choose if they're feeling well enough to participate on Zoom, but not well enough to commute and pay for parking, that they are welcome to join. Each of my groups has 10 patients. I'd say on average, no more than 2 people come in person right now. Part of that is COVID sort of waning COVID sort of caution, because many of these patients have chronic active symptoms. So by definition, they're medically vulnerable. I've seen that increase a little bit in the more recent weeks in terms of some of the groups have more active or more members choose to come in person. And boy, is it powerful. I mean, like you haven't seen somebody in person, or some of these people I've never met in person. It's remarkable. And so I'm delighted that our building and our department provides the capacity to do hybrid group services. And I think we're just going to have to all learn as we go how to do that. So for example, one of the rooms that I use is better for groups because we can all sit around a central conference room table. The other one is more classroom style seating. So we've got to have the in-room participants sit in a line, and then we all look at the big screen on across the room from us. So on the one way that works, especially if I share my screen and show some resources and everybody can see it just like we're doing now. But on the other hand, it's less ideal for the value of sitting in a circle, for example. So more to learn as we all do this work together. You always do right when you end early rather than end late. So I'd like to thank you all, the Zoomers and Roomers, for coming to share my passion for group therapy. I'm more than happy to answer more Q&A individually. Thanks so much. And wait, there's some sort of announcement about, don't forget, other behavioral grant rounds and other stuff ahead. So let us continue to grow as an academic department of psychiatry. That's probably good enough. Manny, is there anything else I have to say or no? Awesome. All right. Thanks everybody for coming. Have a good rest of your days.